Welcome to ENT student. Today we are going to discuss about larynx. First, larynx and its muscles. Muscles which abduct the vocal cords. Posterior cricoarytenoid muscle, which is also called as safety muscle of larynx. Muscle which adducts the vocal cords. There are two muscles, lateral cricoarytenoid and interarytenoid muscle. Muscles which adjust the length is cricothyroid muscle. Muscles which adjust the tension. There are two muscles, ocalis muscle and thyroarytenoid muscle. Nerve supply of larynx. All are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Laryngeal compartments. Larynx is divided into three compartments: supraglottis, glottis and epiglottis. Lymphatic drainage of larynx. Supraglottis. Lymph from supraglottis drains to preepiglottic and upper deep cervical lymph nodes. Subglottis. Lymph from subglottis drains to prelaryngeal and paratracheal lymph nodes and lower deep cervical lymph nodes. Glottis. Vocal cords have no lymphatic drainage. Laryngeal spaces. Rhinky space. It is the submucosal space between the mucosa of the glottis and underlying ocalis muscle. Surgical importance of this Rhinky space is very early glottic cancers remain superficial and rarely penetrate the deeper tissues. Preepiglottic space is also called as space of Bayer. This is fat-filled space lying between the hyoid bone and thyrohyoid membrane anteriorly and infrahyoid bone posteriorly. Paraglottic space. It is potential space between mucosa of larynx and thyroid cartilage. Let's know the functions of larynx. They are protection of lower air passage, phonation, respiration, and fixation of chest wall during climbing, digging, and straining efforts. Carcinoma of larynx. This is more common in males and smokers. There are three types of cancers: supraglottic cancer, glottic cancer. In glottic cancer, small tumor limited to vocal cords and large tumor involving supraglottis, glottis and subglottis. Subglottic cancer, it presents dysphonia on exertion. Classification of carcinoma of larynx: tumor or node or metastatic classification. T. Primer tumor. N. Regional lymphadenopathy. M. Distant metastasis. Hidden areas of larynx: posterior surface of epiglottis, anterior commissure, subglottis and ventricles are the hidden areas of larynx. Pre-malignant conditions of larynx: leukoplakia, erythroplakia, keratosis, papilloma, carcinoma in situ. Thyroplasty. It's a surgical technique designed to improve the voice by altering the cartilages of larynx in order to change the position or length of the vocal folds. Thyroplasty is also known as laryngeal framework surgery. There are four types of thyroplasty. Type 1, medialization. It is indicated in unilateral vocal cord paralysis. Type 2, lateralization. It is indicated in spastic dysphonia. Type 3, shortening. It is indicated in puberty dysphonia. Type 4, lengthening. It is indicated in androphonia in females. Vocal cord paralysis. It occurs when the nerve impulses to your voice box is disrupted. It can be unilateral or bilateral and even complete or incomplete. It is of four types: unilateral incomplete paralysis, unilateral complete paralysis, bilateral incomplete paralysis, bilateral complete paralysis. Pathology. Laryngeal muscles are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Any lesion to the recurrent laryngeal nerve will bring the cord in paramedian position. Any lesion to the vagus nerve will bring the cord in cadaveric position. Simmons law. In any possible lesions of laryngeal nerve, then the abductors of vocal cords are paralyzed earlier than adductors. Abductors of vocal cords are paralyzed earlier because adductors are first to develop, so last to go. Bulk of abductors muscle is less. Chronaxy is more in abductors. Exceptions of Simmons law. Exceptions are seen in tuberculosis of larynx, where cricothyroid is the first muscle to get involved, and Second one is malignancy. Causes for left recurrent laryngeal nerve paralysis: carcinoma of bronchus, carcinoma of esophagus, and carcinoma of thyroid gland, thyroid surgery or radial neck dissection, and mediastinal lymphadenopathy and Hodgkin's disease. Bilateral complete paralysis. It is the most common condition. Both the paralyzed vocal cords are in cadaveric position. Unilateral incomplete paralysis. Vocal cord is found in paramedian position due to bronchial carcinoma. Let's know the examination of larynx. There are two types of examination: external examination and internal examination. Let's see the external examination. For external examination, observe the Adam's apple. It is 90 degrees angle in men and 120 degrees angle in women. Next, check for the laryngeal crepitus. Move the larynx from side to side. A crepitus sound is felt. It is a normal sound produced by the movement of laryngeal cartilage against the cervical spine. Internal examination. It includes indirect laryngoscopy. It is carried out using a laryngeal speculum. The patient is asked to utter a long sound ah and take a deep breath. During phonation and then during inspiration, the inner surfaces of larynx become visible in two phases of the physiological activity. Roentgen automography is an important paraclinical method of examination of the larynx. Structures seen on indirect laryngoscopy. Anterior part of larynx, epiglottis and anterior commissure, seen towards the top of the mirror. Posterior part of larynx, arytenoids and the posterior commissure, seen at the lower position of the mirror. The following things are examined. Epiglottis. The normal color of epiglottis is pinkish. Bright red swollen epiglottis is seen in case of acute laryngitis. Pale swollen epiglottis is seen in allergic laryngitis. Turban-shaped epiglottis is seen in tuberculosis of larynx. Vocal cords. The normal color of the vocal cords are pearly white in color. In acute laryngitis, they are congested. Edema. Edema of vocal cords seen in Reinke's edema. Edge. Vocal nodules or Singer's nodules are seen at the junction of anterior 1/3 and posterior 2/3 of the vocal cords. The malignant growth may be seen anywhere in the vocal cords and requires its removal and histopathological examination. Any solitary nodule can be solitary papilloma. Surface. Observe for any cyst, ulcer, leukoplakic patch or granulations. Movements. The movements of vocal cords are examined at gentle breathing, during phonation, forced inspiration, coughing, and at rest. Vascular tumor is called as hemangioma. Position of vocal cords. There are different positions of vocal cords. First, the median position. When the vocal cords are in midline during phonation, it is known as the median position. Paramedian position. When vocal cords are 1.5 mm away from the midline, this position is in stronger whisper. Cadaveric position. When the vocal cords are 3.5 mm away from the midline, it occurs in complete vocal cord paralysis. Gentle abduction. When vocal cords are 7 mm away from the midline, it is called as gentle abduction. Arytenoids. Array epiglottic floats. Interarytenoids area. Congestion of this area occurs in tuberculosis of the larynx. Glottic chink. Glottic chink is reduced in vocal cord paralysis or any malignant growth. Postcricoid area. Any growth of this area along with absent laryngeal crepitus is highly suspicious of malignancy of this area. Piriform fossa. Fullness of this area is highly suspicious of malignancy. The barium swallow of such patients may show filling defect at the piriform fossa or at esophagus. Upper few centimeter of trachea. Vallecula, median glossoepiglottic fold and base of tongue are also examined after completing examination of larynx. This is the complete view of larynx, its muscles, its nerve supply, lymphatic drainage, carcinoma, and examination of larynx. Thank you, ENT student.